So first, the embryo has to oppose or come close and cozy up to that endometrium physically. Then the embryo has to attach, and the endometrium has to allow it to attach, which means they bind together in a very tight and fixed way. They bind hard to each other and they don't let go. And then finally, that embryo has to invade and implant into the endometrium. So the endometrium has to permit the embryo to invade or grow into itself. So it's a real two-way street, and both the embryo and the endometrium have to cooperate to pull off implantation.
It's a beautiful process, and it doesn't matter how long I have been doing this, I'm still in complete awe of the whole process.
Yeah, it's true.
Yeah, it's really actually quite an incredible thing that so many things have to come together.
Hi, superhumans. I'm Dr. Mavis Garcia.
And I'm Dr. Wise.
We're two of the physician leaders at Markham Fertility Center, otherwise known as our baby, MFC.
As fertility specialists, we've witnessed firsthand the challenges, triumphs, and the myriad of emotions that come with trying to conceive. Whether you're just starting to think about having a baby, actively trying, or facing challenges along the way, My Fertility Podcast will be your go-to resource for honest conversations and a supportive community.
So grab a cup of coffee or tea and settle in, and let's demystify the world of fertility together.
We are very, very excited to have Dr. Crystal Chan joining us today on My Fertility Podcast. Dr. Chan is the scientific director here at Markham Fertility Center, and she is a reproductive endocrinologist and surgeon, and is assistant professor in the Department of Obstetrics and OB-GYN and the Department of Lab Medicine and Pathology at the University of Toronto. She is also our very, very dear friend and fellow co-owner of Markham Fertility Center. I first met Dr. Chan when I was a resident at U of T, and I thought she was the coolest person ever. And I always wanted her to be my friend. And so the fact that now, many years later, we get to work together in this capacity, now she gets to be a guest on our podcast, is really, really exciting for me. So welcome, Dr. Chan.
Thank you. And I'm so happy to be here because I've had the greatest FOMO watching you guys live this life of the podcast celebrities and basically living the Barbie movie without me. So I'm so happy that you invited me, and thank you for sharing this opportunity.
Well, you'll always be one of the Barbies with us. You know that.
Definitely.
We're really looking forward to this, Dr. Chan. So today, I know that you are an expert on many things related to fertility, but there is one particular area of reproductive endocrinology and infertility that you're very passionate about, and that is the endometrium. So I wanted to spend some time today talking about the endometrium, endometrial receptivity, and the different tests that we do for that, and sort of picking your brain about what is the role of the endometrium in reproduction and how do we go about testing it.
Really, before I came into private practice, studying the endometrium and doing research on implantation was really the point of my whole career, my existence. So it was really nice to be able to debrief and to recap what I spent years studying.
So of all the cool things in reproductive medicine, why did you choose to research the endometrium in particular?
I'm very happy to talk about my path towards studying the endometrium. So I think, like all of us, I knew I wanted to be a fertility doctor from very early on. So in medical school, I learned about what IVF was. I don't think I had a great awareness of what IVF was prior to medical school, but I do remember learning about it at that time. And I learned about the pioneers of IVF, Dr. Robert Edwards, Dr. Patrick Steptoe, and their nurse Jean Purdy. And these people were visionaries. In the 1970s, they devised in the lab a way of combining oocytes or eggs and sperm to make embryos and putting those embryos back into the uterus to achieve pregnancy. And they were really innovative at the time. People thought they were crazy. In the 70s, they received hate mail. I think, one of the conferences we went to recently, we saw some of that hate mail. They got brutal hate mail accusing them of perverting nature. But these visionaries didn't care. They kept their nose down. They kept working on what they were working because they knew that the technology would make such a difference to humanity that they just kept going. And here we are, almost 50 years later, and almost 10 million IVF babies later. And looking back, it's thanks to them and their innovative spirit that we're even here. So when I learned about how cool IVF was, when I learned about what the pioneers of IVF had to go through with their innovative spirit, with their research, and with their commitment to science, I wanted to do exactly that for my career. So I wanted to be a fertility doctor. I wanted to be a researcher and a scientist. And then I got to my OBGYN residency, and that was the time that I had to, in a way, determine or declare my niche, my research interest. What area of reproductive medicine would I research that could make the biggest impact and leave the greatest legacy? Where was the gap, in our field? And this was about 16, 17 years ago. And all the cool kids were studying other things. They were studying oocytes or eggs, sperm, embryo development, pre-implantation genetic testing. Not a whole lot of people, some people, but not a whole lot of people were studying the endometrium. And I think there was something that I read around that time of career development written by Dr. Robert Edwards, who is the father of IVF. And he passed away in 2013, but in 2006, he wrote a piece that was entitled Human Implantation, the Last Barrier in Assisted Reproductive Technology. So he spoke about all the different things that were required for implantation to occur. And a lot of it is up to the embryo health, the embryo genetics, the embryo energy levels. But we know that it's not just the embryo. So even in top clinics like our own, even with genetically screened top quality embryos, the pregnancy rate we know is about 70% per embryo transfer. So what is happening to those 30% of good embryos that we're putting in that aren't implanting? So it's really, we think, not only a good embryo that you need, but what's equally important is a healthy, functional, viable, lush, receptive endometrium. And not a lot of people were studying this black box. That's what I call it, the black box of the endometrium. And call me a contrarian. I think you guys often call me a contrarian, but I wanted to study what other people were neglecting. And so that's what I did. I did a Master's of Science degree in my residency. I traveled to University of California in San Francisco for a visiting fellowship to learn how to culture or grow endometrial cells in the laboratory. After graduation from fellowship, I came on staff at Mount Sinai Fertility Clinic as a clinician researcher, and I had my own wet lab at the Lunenfeld Tannenbaum Research Institute at Mount Sinai. I had postdoctoral fellows and students. I wrote grants. And that research was really centered around what makes the endometrium receptive. And that research allowed me to see the world, travel the world, give talks, disseminate my findings. And it was a very exciting time of my life. I mean, I obviously think about it fondly, but I gave it up for you guys. But, it was a very meaningful, exciting time of my life. And now I've transitioned to a more private practice role, but I still have some of these research inclinations for sure.
And we love that about you. And we're very excited to see what kind of research you're going to be doing here at MFC.
Yeah, we still need your research genius, our MFC. The world still needs it.
Yes. Yeah. And I plan to continue. Yes.
Good. So tell us a little bit more about the uterus, and in particular, what exactly is the endometrium?
Think about the uterus as a squash. I like to use this analogy. So there's 3 main layers of the uterus. The outside layer of the squash, or the peel, would be what's called the serosal layer, serosa of the uterus. The middle layer of the squash, which would be the flesh of the squash, would be the myometrium, which is mostly muscle. So that's the middle layer of the uterus. And then the inner layer of the squash, the part that has the seeds, that inner lining in the uterus is called the endometrium. So from outside in, you have serosa, myometrium, and endometrium. And the endometrium is the most sacred part. That is the part where all the action happens in terms of implantation. That's the part we really, as reproductive endocrinologists, probably care about the most when we talk about fertility and assisted reproduction. So the two of you gave a great podcast about the menstrual cycle. So I want to talk a little bit about what the endometrium does over the course of the menstrual cycle. It's beautifully predictable and dynamic over the course of the menstrual cycle. So right after the period, under the influence of estrogen being produced by the ovary, the endometrium thickens, also called proliferation. So that part, or that phase of the menstrual cycle, is known as the proliferative phase. And if ovulation happens, after ovulation, progesterone is produced by the ovary, and progesterone causes the endometrium to stop thickening and to become what's called secretory. So then the endometrial cells start to produce a host of different factors that are meant to hopefully facilitate embryo implantation. If embryo implantation occurs, then that endometrium continues to secrete these factors and to facilitate implantation. And if pregnancy does not occur, that endometrium breaks down and sheds as another period, and the whole cycle repeats. So when we're talking about embryo implantation, the embryo, if it's a naturally conceived pregnancy, the embryo drops into the uterine cavity near the endometrium by coming down the fallopian tube and dropping down that way. If we're doing IVF, we're inserting the embryo through the cervix from below into the uterine cavity. It ends up in the same place. So at some point, we hope that the embryo and the endometrium have a chance of meeting. So what needs to happen for implantation to occur is the embryo and the endometrium have to communicate. There has to be a dialogue, and we think a lot of that happens on a molecular level. And there's 3 things that need to happen. The embryo has to do this, and the endometrium has to be an active participant. So first, the embryo has to oppose or come close and cozy up to that endometrium physically. Then the embryo has to attach, and the endometrium has to allow it to attach, which means they bind together in a very tight and fixed way. They bind hard to each other and they don't let go. And then finally, that embryo has to invade and implant into the endometrium. So the endometrium has to permit the embryo to invade or grow into itself. So it's a real 2-way street, and both the embryo and the endometrium have to cooperate to pull off implantation.
It's a beautiful process, and it doesn't matter how long I have been doing this, I'm still in complete awe of the whole process.
Yeah, it's true.
Yeah, it's really actually quite an incredible thing that so many things have to come together. To be honest, I'm still always surprised that pregnancies even happen when you think about all the events that have to take place for a pregnancy to occur. So you mentioned endometrial receptivity a few times. What is endometrial receptivity, and how do we know, when does it happen during, let's say, the menstrual cycle?
Great question. So very broadly, endometrial receptivity is the ability of the uterus or endometrium to facilitate embryo implantation. So the endometrium probably isn't just a passive thing that just allows every embryo to implant. It's a very intentional state of the endometrium to be able to allow that embryo to oppose, attach, and invade. And in fact, we know that this is a very time-limited situation within the endometrium. So the endometrium is not always receptive to the embryo. And in fact, in most of the menstrual cycle, it is definitely not receptive. You can take the most beautiful genetically tested normal embryo in the world, you can take 5 of them, and you can put it into a proliferative phase lining prior to ovulation with no progesterone exposure, and you will not get a pregnancy. I'll bet my last dollar that you won't. And that's because at that time, the uterus is not receptive. So when is it receptive? There have been lots of classical research studies on this, and it seems to be that the natural window of implantation starts approximately 5 days after ovulation and lasts up to 5 days. So if you take that same good quality embryo, 5 of them, and you put that embryo into a uterus or an endometrium that's post-ovulation day 5, 6, 7, 8, you'll probably have a good chance of pregnancy. So it's a time-limited window, probably about 5 days broad, in the mid-secretory phase, starting about 5 days after ovulation.
And how do we create this endometrial receptivity in a frozen embryo transfer cycle?
People are freezing embryos these days for various indications. Sometimes people don't feel like doing their embryo transfer yet. Sometimes they're doing pre-implantation genetic testing or PGT, and that necessitates having to freeze the embryo for a later transfer. Sometimes people are freezing embryos from one partner and putting the embryo into another partner. So I would say at this point, frozen embryo transfers outweigh fresh embryo transfers. We do way more frozen embryo transfers, right, than fresh transfers. So when we're trying to do a frozen embryo transfer, we're trying to mimic or recreate the natural menstrual cycle and the natural secretory phase. I think a lot of what we do in fertility is not that complicated. I think a lot of people make it sound complicated, but we're just trying to copy nature to the best of our ability, right? So in a medicated frozen embryo transfer cycle, what we're doing is we're giving somebody, a patient, estrogen tablets usually, or estrogen patches. And that is for the purpose of trying to thicken the endometrium. So we're trying to copy the proliferative phase by giving estrogen tablets for about 2 weeks. And then people come in for an ultrasound. And if the lining looks adequate, which I'll talk about later, then we'll start progesterone. And on the 6th day, usually, of progesterone exposure or administration, we will thaw an embryo and transfer that embryo. And that really is meant to, if you think about that window of implantation, window of receptivity, it's meant to recreate that. There's also another way to do embryo transfers called natural frozen embryo transfers, where we don't give estrogen and we just do cycle monitoring of a natural cycle to watch for ovulation, and then about 6 days later transfer the embryo, 6 days after the LH surge. And that's a different way of doing things. But basically in both medicated and natural frozen embryo transfer protocols, we're trying to copy and recreate that window of receptivity of the uterus.
What causes abnormal endometrial receptivity then?
Yeah, so this is a big question, and I'll start by talking about obvious organic or structural problems of the endometrium or adjacent structures that are pretty easy to diagnose. So basically, you can see these problems. One thing that we deal with a lot is uterine polyps, which are benign growths or sometimes called overgrowths of the endometrium. So you can have these little benign growths in the endometrium that might impede receptivity and implantation. The second thing is fibroids. So fibroids are all about location. Not every fibroid is a bad fibroid from the point of view of reproduction, but fibroids that are what we call submucosal, the ones that protrude into the endometrium, probably do alter receptivity. The third thing is, this is a very frustrating condition to treat, is called Asherman syndrome. I know I can speak for all of us when I say it's a very difficult condition to treat. This is extensive scarring or damage of the endometrium, usually from previous surgery and or infection, which can really negatively affect how well an endometrium can receive an embryo. Now, these first three things are easy to detect by sonohystogram or hysteroscopy. Now, other than these three endometrial disorders, there's also something called hydrosalpinx. Hydrosalpinx is where the fallopian tube is blocked at its end, and when there's that blockage of that pipe known as the fallopian tube, the secretions of the fallopian tube and old menstrual blood can get trapped in that tube and make it bloated with fluid. And we think that fluid that's contained in that hydrosalpinx can lead to decreased endometrial receptivity by trickling down into the uterus cavity. So that actually has been shown to decrease endometrial receptivity and implantation by about 50%. And then finally, the last structural or organic or visible, cause of decreased endometrial receptivity would be endometriosis. March was Endometriosis Awareness Month, and you two ladies did a remarkable job in highlighting how horrible this condition can be for a lot of people and how it can affect fertility. As has been talked about, endometriosis is where you have endometrial cells that migrate outside the uterus and grow in the pelvis and other places in the body. And it's very interesting and distressing that it's been shown that the endometrium in the uterus of patients with endometriosis do exhibit altered or potentially reduced receptivity. So there are several studies that show that if you biopsy endometrial cells from patients with endometriosis, they have a different pattern of gene expression from people without endometriosis. So those are the organic and structural causes that we as fertility doctors are very used to testing for and trying to rule out and trying to optimize for our patients. But the scary cause of abnormal endometrial receptivity would be the one that we can't see, that we can't diagnose. Because even in the absence of structural problems or any of the above issues that I just talked about, some people do have a history of repeated implantation failure. Some people have a history of recurrent implantation failure, which is where they've transferred multiple good quality embryos and still no pregnancy. And they have assessments of the uterus that show a very normal looking endometrium without any of these problems. So likely on a molecular level, there are some people with abnormal endometrial receptivity, but we can't find a polyp, we can't find a fibroid, we can't find a hydrosalpinx. And these are the cases that keep us up at night. These are the cases that we need to find better ways of diagnosing endometrial receptivity and treating these problems.
That's very interesting. And you said something that's very true. I mean, that these are the cases that keep us up at night in patients with recurrent implantation failure. And I can definitely attest to that as well. And so let's say you have a patient who has recurrent implantation failure. You've assessed for polyps, the fibroids, Ashermans, you've ruled out those things. Where do you go next? Are there tests of endometrial receptivity? What else can we do?
Sometimes it's easy to sort of throw up your hands and say, well, we can't do much. Let's keep trying to transfer more embryos. And that is one approach. But there are tests, and I'll talk about the most standard test first, which is ultrasound and what we can glean from ultrasound. And then, if it's okay, I'll talk about some of the more sophisticated and molecular-based tests. So first, ultrasound. Every fertility clinic does ultrasound. Every fertility doctor uses ultrasound as their main diagnostic tool. We're very comfortable with it. It has become really the standard of care for assessing the endometrium prior to embryo transfer in IVF. And for the past 30 years, transvaginal ultrasound measurement of the endometrium has been the mainstay of determining before embryo transfer if the endometrium is ready. So when do we measure the endometrium or test the endometrium with ultrasound? And we actually measure it at the end of the proliferative phase. So let's say you have a patient who's about to have a frozen embryo transfer. And let's say, like Dr. Garcia had mentioned, we're doing a medicated frozen embryo transfer protocol. So this person has been on estrogen tablets for about 2 weeks. So after the estrogen treatment has been administered, we usually do an ultrasound to gauge the thickness of the endometrium. We measure the endometrium, and then we use that endometrial thickness measurement as a predictor of whether the endometrium is ready for implantation or not. The question always is, how thick is thick enough? And there was a publication by one of my ex-colleagues, Dr. Kimberly Liu, which looked at just that. It was a fantastic study looking at over 40,000 data points from fresh and frozen embryo transfer cycles using Canadian Assisted Reproductive Technology data. So Canadian Assisted Reproductive Technology Registry data. And what she found is that for frozen embryo transfers, an endometrial thickness 7 millimeters and above is optimal for prediction of implantation. And for every millimeter under 7 millimeters, the pregnancy rate was reduced. So it seems like from that study that 7 millimeters is the optimal threshold. But we all know that some patients can't get to a lining thickness of 7 millimeters. Some people have a little bit more difficulty getting to a thicker lining. So it is important to note in that study that the pregnancy rate never went to zero at any endometrial thickness. They even reported pregnancies at 4 millimeters of endometrial thickness, which traditionally was too thin to transfer. So there's never a point where that pregnancy rate goes to zero. So the point is, I don't think that endometrial thickness is the be-all and end-all. Yes, over 7 millimeters is ideal and optimal as a target, but some people don't get to that and still you can have some pregnancies. So endometrial thickness is an okay predictor of implantation and endometrial readiness, but is not everything. Many people have also tried to look at the pattern of the endometrium at that time, at the end of the proliferative phase. Traditionally, we like to see what's called a trilaminar or triple line pattern of the endometrium. And if you look at ultrasound images, you can see very clearly what that means is you see 3 stripes, 3 lines through the endometrium. That's thought to be a more favorable pattern that predicts implantation. But if you look at a lot of the research studies, it hasn't really panned out that it's that accurate. And one of the main reasons is that there are certain situations where a triple line is not easy to see. Like if the uterus is at a certain angle or position, if the body weight of the patient is a little bit higher, there might be a triple line, but you might not be able to see it. So pattern is not that accurate, and we tend not to use that as an indicator. Now, a lot of astute patients and students of mine have said, hey, Dr. Chan, you just said that the standard of care is measuring the endometrium at the proliferative phase. Now, that's like a week before you do the embryo transfer. That's like pretty far out. So why doesn't anybody try to do an ultrasound the day before an embryo transfer or the morning of an embryo transfer before you thaw the embryo to see if the lining is ready? Well, one of the issues there is that the endometrium does not thicken any further after ovulation or after progesterone exposure. And in fact, in some people, the endometrium undergoes what's called compaction. Now, Dr. Bob Casper in Toronto, another REI, has spent a long time studying this phenomenon. And it does seem that for some people, after exposure to progesterone, that lining actually thins out or compacts. And that group has really tried to see if this phenomenon can predict implantation, but it hasn't really panned out again. There's huge variation in how much people compact or don't compact, and it's not a very accurate predictor. And so it's kind of fallen by the wayside a little bit, I think. And there really aren't good thresholds, or like for the proliferative phase, we know 7 millimeters may make a difference, but with after progesterone exposure before the time of embryo transfer, we don't know what number we need to have to predict implantation. So that's not a good tool. What we do have, these ultrasound-based assessments, it's very crude. That's why we all know the endometrium to be a real black box. And so probably about 15 years ago, many researchers, including myself, started to look at the endometrium and to see if there were any molecular factors that might be able to predict implantation, not just looking at the lining on ultrasound, but looking at genes, looking at DNA expression. So there was a lot of excitement and fanfare about 13 to 15 years ago when this product came out called the endometrial receptivity analysis, or ERA product. It was really a pioneer. It was the first to market in terms of a molecular test for endometrial receptivity. This is how the ERA test works. It's meant to help you determine the best time to transfer a frozen embryo. Let's say you have a patient who you're trying to do a medicated frozen embryo transfer on, and you're trying to determine the best time to put the embryo in. You would put this patient through what's called a mock cycle or practice cycle. You would give that person estrogen for a couple weeks, and if the lining got thick enough, you would then give them progesterone. And on the 6th day of progesterone, usually when we would do an embryo transfer, we would do an endometrial biopsy. It's a little bit of a painful test. It's where we insert a tube into the uterus and extract some cells. And then we could send those cells for ERA testing. It's not covered by any provincial health plan. It would be a private pay procedure. And you could send this biopsy for an analysis of about 250 genes that have been shown to be predictive of the endometrium's ability to implant. And from the pattern of these genes, how on or off these genes are in the endometrium, the test would tell you if the uterus or the endometrium is receptive or non-receptive. And the idea is that if it's receptive, that's a good time to do your embryo transfer, and we would transfer on that date in a subsequent cycle. And if it's not receptive, it would either be what's called pre or post-receptive. And so the test would suggest that you adjust your day of transfer one day later than the biopsy or one day earlier. And the test claims that there's this specific window of 12 to 24 hours where it's really the best time to transfer that embryo. So that's one test. It's called the ERA, and it's to personalize that timing of implantation. And there's other molecular tests that exist. There are some that look at the microbiome or the bacteria within the uterus. By sequencing DNA, they can tell the relative proportions of bacteria. There's another test that looks for a protein called BCL6 that's associated with endometriosis. But these other tests, the microbial test and the BCL6 endometriosis test, they really haven't been proven either to improve implantation rates.
That's a fantastic summary of a lot of the endometrial receptivity tests that we have on the market. But I guess, what are the limitations, or how do you counsel your patients about navigating whether they should do these tests or which tests they should do or when they should do them?
It's a great question. So there are a lot of limitations, although there was a lot of excitement about the ERA product. And by now, a lot of patients, probably close to 500,000 in the world, have done an ERA test, or either in clinical practice or in a research setting. I think everybody was very hopeful that the ERA test would be like the black box decoder, and that would solve the problem of endometrial receptivity. And indeed, there were very encouraging publications about the ERA. There have been studies showing that patients with recurrent implantation failure, so patients with repeated failed embryo implantations, probably something truly wrong with their endometrial receptivity, those patients are more likely to come back with what's called a non-receptive ERA result, like there's something off about the genes. There are also encouraging publications showing that the ERA is quite reproducible, meaning that if you take an ERA biopsy in January, 6 days after progesterone exposure, and you take another biopsy in June, you're probably more than 90% going to have a similar result. But the problem is that there have not been a lot of studies that have shown that the ERA actually translates to higher pregnancy rates, that if you do an ERA and you correct or adjust the day of embryo transfer according to the ERA result, we're not seeing a lot of convincing data that it actually elevates the pregnancy rates. In our own clinic, and we've looked at this data, we have two groups of people, people that did the ERA and people that didn't do the ERA. The people that did the ERA would generally correct or change the day of their transfer according to it. So ERA corrected transfers versus non-ERA corrected transfers. And our pregnancy rate in each group is very similar. We do great. We have 70% pregnancy rates per high quality genetically screened embryo transfer, but it doesn't seem to be improved or modified that much by the ERA. So that has been a little bit disappointing. That has been a lot disappointing.
Yeah.
And I think one of the most concerning studies that came out was in September, about a year and a half ago. It was a multi-center study that showed in a few sites, I believe in Italy and Spain, they did the ERA on patients that had failed an embryo transfer in the past. And they found in that one study that their ERA corrected patients, the ones that actually did the ERA and changed the day of transfer, actually had lower pregnancy rates than if you didn't do the ERA. So that was a study that I think scared off a lot of patients from doing the ERA. And we saw a marked decline in our ERA usage after that study came out. I think, again, I can speak for the three of us, that the ERA is not bad. The ERA has its place. Sometimes when people have recurrent implantation failure and we don't know what else to do, we still do the ERA to try to characterize if there's an endometrial receptivity problem with the genes. But I think the big problem is that changing the day of the transfer, adding 1 day or subtracting a day, doesn't seem to translate to better pregnancy rates. So it might be a good diagnostic tool. It does come back more likely to be abnormal or non-receptive in patients with implantation failure. But I think it's a bit naive to think that just tweaking the day of the transfer is going to solve your endometrial receptivity problem. I think we all mention the ERA to our patients as they're going through their frozen embryo transfer journey, but really it's an elective or a patient choice kind of thing. And yes, if I've seen someone fail 2 or 3 top quality embryo transfers, I might bring up the ERA as a diagnostic tool. Another problem with the ERA and tests like the ERA is the endometrial biopsy. So the biopsy is invasive, it's painful, it should not be done in the same cycle as the cycle you're planning to transfer the embryo because we worry it might disrupt the endometrium in that cycle. So it can only be done before. And even though it's 90% plus reproducible, it's probably not 100% reproducible. And so that's a lot of the criticism of the ERA, that it's not a point of care test. Like you're not testing right before you put the embryo in. You're testing the endometrium 1, 2, 3 months prior to that. And then the last limitation that I kind of like to talk about with the ERA is that endometrial nerds like myself, I've studied for 15 years that the endometrial window of receptivity is 5 days wide. So it's really, really hard for me to believe that there's like a special 12 to 24 hour window that you have to transfer the embryo or like you're going to expire afterwards. It doesn't make biological sense to me. I do think that there's ample data to show that that window of receptivity is broad enough that you don't have to do the ERA on everybody and like run and put the embryo in at exactly this one time or right time.
That's great. Thank you. I do have a question in follow-up to a prior comment that you made. So you mentioned how in endometriosis, there could be increased incidence of abnormal endometrial receptivity. So I'm wondering, how do you go about doing an embryo transfer in somebody with endometriosis? Do you recommend an ERA more in somebody that has endometriosis and doing an embryo transfer?
Such a great question. Can I say I don't know? So
I'm glad that you're saying I don't know because I also don't know. So I feel less lonely not knowing.
For the record, I also don't know.
So endometriosis is, you did a whole podcast on it. And from that podcast, one of the basic messages is endometriosis is complex and heterogeneous. Heterogeneous meaning that there's a whole bunch of different ways somebody with endometriosis can present. Some present with pain, some present with no pain. Some present with infertility, some are very fertile. So it's not an absolute, endometriosis doesn't define you. It doesn't make for just one presentation or just one picture. That's a little bit of a problem with endometriosis research in IVF. First and foremost, not everybody with endometriosis has infertility or implantation failure. If you look at the data, patients with endometriosis versus patients with no endometriosis have very similar implantation rates when you're putting in euploid genetically screened embryos. So even though there are basic science studies that suggest an altered gene expression picture from biopsies of people with endometriosis versus not, when you actually go to clinical practice, you'll find that as long as you can get that very high quality embryo and you put it in, the the pregnancy rates are actually statistically very similar, thankfully, between endometriosis, yes or no. You can't cure endometriosis. That's another message. But a lot of people have tried to give medications to make endometriosis dormant, such as treatments like Lupron, which puts people in temporary menopause, and then do a frozen embryo transfer, a medicated frozen embryo transfer after that to see if they can improve pregnancy rates. And if you look at data on what's called downregulated medicated frozen embryo transfers, the pregnancy rates don't seem to be much better at all than what we often do, which is a natural frozen embryo transfer. So I think my answer to that question is I don't treat people with endometriosis differently from an FET protocol design standpoint from people without endometriosis. But if there's a patient with endometriosis that has failed multiple embryo transfers, sometimes I will try, because there's not much else we can offer, I will try to give them downregulation if they have failed multiple, standard natural or standard medicated FETs. But it's not my go-to because it really hasn't been proven, I think, to increase implantation rates.
Thank you. Thank you for clarifying that. That's great. So, being the expert that you are on the endometrium and being such a trailblazer and such a person with a futuristic vision, what do you think the future holds for endometrial receptivity assessment?
I think that's where the industry has to spend some time and attention. Let me be cynical for a moment. 20 years ago, the pregnancy rate per embryo transfer in the world was probably about 20%. Now, in top clinics like our own, when we're genetically screening embryos, putting in high-quality genetically tested embryos, the pregnancy rate has improved to, let's say, 70% per embryo transfer. So we've done remarkably well as an industry, as a group of scientists and clinicians. But I've noticed, and I think we've all noticed, that there's been a bit of a plateau. So this 70% has been the case for the past 5 years, 7 years. It hasn't really got appreciably better in the past little while. And I think we've gotten very good at screening embryos, making embryos, or developing embryos, choosing embryos. But we haven't done anything on the side of the endometrium to directly improve endometrial receptivity. The only thing we've done as an industry is change the day of your transfer. So the next step, and it's not going to be me or just me, is to develop directed therapeutics, to use the DNA gene expression data that we're getting from the endometrium, that we have a lot of data for, to actually design therapeutics, medications, treatments that will directly go to the uterus and improve that state of endometrial receptivity and improve the ability of the uterus to accept an embryo. So that's something that's bound to happen or should happen. The second thing, and I'm going to sound like a cliche, but it is artificial intelligence or AI. So AI in diagnostic healthcare, the basic premise of AI in diagnostic healthcare is that maybe the human eye and the human brain is not sufficient to detect subtle patterns that might predict pregnancy outcome. So people are using AI and machine learning to look at transvaginal ultrasound images to see if the image, if there's something the human eye can't pick up that might predict implantation, that might predict endometrial receptivity. So that work is being done. And my own group has published data looking at using AI to look at endometrial biopsy samples under the microscope to see if there's any patterns that are seen in the endometrial biopsy tissue under the microscope that can predict, again, endometrial receptivity and implantation later on. So that's another important facet, is what can AI do for our diagnostics. It's probably not going to fix therapeutics at this point, but at least for the diagnostic component. And then the third thing, and this is what I really developed in my 10 years doing research on the endometrium, is non-invasive or less invasive methods of uterine endometrial sampling. So the standard of care of all these molecular tests is to do an endometrial biopsy. And an endometrial biopsy is painful, and it hurts, and it's invasive, and it can't be done in the same cycle as an embryo transfer. So what I really spent 10 years doing is developing a technique called uterine fluid aspiration, UFA, which allowed us to take out a few microliters, just tiny little amounts of fluid from the uterine cavity right before transferring an embryo. And we can glean all the same information on a genetic level that you can get from an endometrial biopsy. So that technique is out there. It's been published. And I think if somebody really has the appetite to do it, I could imagine a molecular test based on UFA aspiration as opposed to a painful invasive biopsy. And that would really be a point of care test that you could test the endometrium right before transferring the embryo.
That would really be the dream. No pain, and a test that tells you exactly what is happening just before the embryo goes in.
Yeah, it's fantastic. And
Yes.
I hope that we will all get to see that fairly soon. We'll be able to offer it to our patients soon. We're just wrapping up here, but I'm going to put Dr. Garcia on the spot here because I'm worried that Dr. Chan's not going to give us a totally honest answer. So, Dr. Garcia, why don't you tell us your favorite fun fact about Dr. Chan that you think people will be most surprised to know about?
Oh, that's a tough one. I have so many to pick from. Well, one thing about Dr. Shan that I actually, when I first learned this, I thought it was weird. But now I really
on.
love it. I really love it. And it's the fact that she's obsessed with the zombie apocalypse. She's quite sure it's going to happen. She thinks it's happening every weekend.
Yeah, that is,
And
I can definitely attest to
she's
that as well.
she's
Yeah.
quite ready for it. And if it does happen, I am coming to her house because she and her husband are gonna get us out safely onto the spaceship to the other planets. We have a deal.
So in my defense, I do think at some point in humanity, a cataclysmic apocalyptic event will happen. I'm not sure if it's the zombies. I'm not sure. But it might be something, and we should be prepared for the possibility. So pack your bags, get a big truck, and be ready.
I still remember that one time when we were in clinic and we were reviewing the consent forms for frozen embryo transfers, and we were thinking about updating them, et cetera. And you suggested that we should put a clause in there that we will send embryos to space in case of the apocalypse. And you were quite serious about that. Thankfully, I can tell everyone that that clause is not in the FET consents, thanks to the efforts of myself and Dr. Garcia. But who knows, maybe in a future iteration.
Yeah. But I have to say, I mean, there was a great
maybe best to not publish that.
Yeah.
Awesome. Thank you so much for joining us today on My Fertility Podcast. Honestly, I've learned so much, even though I get to hang out with you on a regular basis. And it's always fantastic to hear your take on endometrial receptivity and sort of where things are going. We're definitely going to have you back on as a guest at some point in the future.
I certainly echo that comment, even though we get to hang out quite a bit. And I'm so privileged to call you my partner and my friend. I've learned so much today. So thank you for your time.
Thanks for having me, guys.
Okay. See ya. See you in about 5 minutes.
See ya.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at markhamfertility.com. And don't forget, follow, subscribe, and share your favorite episodes.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music from Mix Kit Raising Me Higher by Ajay Stelino. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.